Hi, everyone. Can you hear me?
I can, yes.
Okay, great. I think I just promoted everybody to the co-hosts. So Caitlin, Julie, and Mary Grace, you've all been promoted to the co-host.
Perfect. Thank you so much.
Yeah. Sorry, we're in the middle of BGY2 interviews, so I've been running back and forth.
That's fine. I think everyone understands that. Welcome to everybody who's just joining. We're going to give everyone a few more minutes just to locate the Zoom link and hop on, but we'll get started shortly. All right, everyone, good afternoon and welcome to the second webinar of 2022 in the ACCP IMTR PRN series. My name is Caitlin Mardis and it's my pleasure to serve as your moderator for today. I'm joining you today from Columbia, South Carolina, where I'm a faculty member at the University of South Carolina College of Pharmacy. So as you all can tell from the screen, today's webinar is entitled Osteoporosis and Solid Organ Transplantation, and we are honored to have Julie Mandel and Mary Grace Fitzmaurice here with us to present today. Just for some brief introductions, Julie received her PharmD degree from the University of Pittsburgh School of Pharmacy in Pittsburgh, Pennsylvania, and she completed her PGY1 residency at North Shore University Hospital in Manhasset, New York, followed by her PGY2 Solid Organ Transplant residency at Ochsner in New Orleans. She's currently a clinical pharmacist specialist in solid organ transplant at University of Pittsburgh Medical Center Harrisburg in Harrisburg, Pennsylvania. Mary Grace also received her PharmD degree from the University of Pittsburgh, and she completed her PGY1 and PGY2 residency training at the Cleveland Clinic main campus in Cleveland, Ohio. And she's currently a clinical pharmacy specialist at Henry Ford Hospital in Detroit, Michigan. So in a moment, I will turn it over to Julie to begin the presentation, but I did just want to provide a few quick items of orientation before we get started, particularly given the Zoom platform, which may be different from the past webinars. So for our audience members, just please ensure that your microphone remains muted for the duration of the presentation. That's located in the lower left-hand corner of your Zoom screen if this isn't the platform you've used most frequently over the past few years. And if at any point during the presentation you have a question for the speaker, we would ask that you submit that using the chat functionality at the bottom of your screen. But we would appreciate if you would send that directly to me as the moderator using the drop-down, just to minimize any interruptions, and then I can facilitate all of those question and answer at the end of the presentation. So if you experience any technical difficulties during the webinar that aren't fixed just by logging out or refreshing your internet connection, you can certainly make me aware of that as well via the chat functionality. And lastly, today's webinar will be posted on the YouTube channel for future reference if you'd like to locate that in the future. But now I'm excited to hand over the reins to Julie to begin. So thank you so much, Julie.
Thank you, Caitlin. Can you hear me okay?
Yes, absolutely.
Okay. Thank you for that introduction and the opportunity to speak to you today. We're going to go over the pathogenesis and underlying mechanisms of osteopenia and osteoporosis, discuss risk factors specifically in solid organ transplant patients, and then go over pharmacologic interventions for both prevention and treatment of osteoporosis in transplant patients. So a little bit of background to get started. Osteoporosis, it's often called the silent disease. It's typically unnoticed until patients either break a bone or have a fracture. But despite this, the majority of high-risk individuals that have experienced at least one osteoporosis-related fracture are either failed to be identified or treated. Findings from the 2017-2018 National Health and Nutrition Examination Survey by the U.S. Department of Health and Human Services found that over the past 10 years, the prevalence of osteoporosis in the United States has significantly increased among adults aged 50 and over, and that prevalence being higher among women than men. And because of both this omission of osteoporosis identification among the affected patient population, as well as the increasing prevalence of the disease, Healthy People 2030 has incorporated 2 osteoporosis-related objectives, including increasing the proportion of adults that get screened and increasing the proportion of adults that get treated after developing a fracture. I like to think of fractures as the endpoints in osteoporosis, kind of like developing an MI or a stroke and cardiovascular disease. The risk of fractures in solid organ transplant is about 5 times greater than that of the general population, and there's some variability in the reported percentages of risk based on the literature and the organs, and this risk can increase or decrease over time post-transplant based on patient-specific and medication-specific factors, which we'll discuss. Fractures have a multitude of consequences, including decreasing patients' quality of life, limiting mobility, and increasing healthcare costs due to the extended need for rehabilitation services after developing a fracture. And once someone develops an initial fracture, the risk of subsequent fractures is extremely high, leading to more complications. So therefore, preventing and treating osteoporosis in transplant patients is essential. Going back to anatomy and physiology, our bones have many functions, including protecting organs, providing body structure, and storing minerals. Humans exhibit bone growth from birth until adulthood, with peak bone mass achieved around 30 years of age, followed by a further decline. Bone mass and structural integrity is maintained through the cycle of remodeling, by which our old bone tissue is replaced with new bone tissue. And this is primarily done by 2 cells, our osteoclasts, which cut down bone, and osteoblasts that build up bone. So the osteoclasts remove old bone tissue through resorption, and then osteoblasts lay down collagen and synthesize new bone matrix. And this process continues throughout our lifespan, with about 10% of our bone being replaced each year, meaning about every 10 years, the entire skeleton has been replaced. So it's a dynamic process that's continuous removal and replacement, and there's a variety of hormones that regulate the process. Receptor activator of nuclear factor kappa beta ligand, or RANK-L, is produced by osteoblasts and is responsible for activating osteoclasts and stimulating bone resorption. Parathyroid hormone, or PTH, increases production of RANK-L and further stimulates resorption. In contrast, hormones that inhibit bone resorption include osteoprototegrin, or OPG, as well as estrogen and testosterone. So ultimately, we need a balance of these hormones to regulate remodeling, and when imbalances develop that favor resorption, that's when osteoporosis develops. And the word osteoporosis literally means porous bones, so you can see the drastic difference in the bone matrix with and without osteoporosis. It's formally defined as a bone disorder that increases risk of fracture due to three features. First, decreased bone mineral density. Two, impaired bone architecture, and this means the thickness, porosity, and geometry of the bones. And then lastly, decreased bone strength. In the general population, primary osteoporosis is associated with age and sex hormone deficiency, which we most commonly see in postmenopausal women due to reductions in estrogen. But additionally, there's a variety of secondary causes, and a lot of these are common to see in transplant patients both before and after transplant. So any disease states that affect hormone regulation and parathyroid hormone can cause osteoporosis. Nutritional deficiencies and prolonged immobilization also contribute. And then a lot of medications, most notably the glucocorticoids. But a lot of patients are on a combination of these medications and underlying disease states, so they have additive risks. For diagnostic purposes, the World Health Organization defines osteoporosis as either a Dexa Scan T-score less than or equal to -2.5, or occurrence of a fracture regardless of bone mass. And then osteopenia is defined as low bone mass that's not quite low enough to reach osteoporosis diagnosis, but this is a key population that we should be targeting for preventative therapy, especially if they have osteopenia coming into transplant. There's a high likelihood that without prevention, they'll progress to osteoporosis. Dexa Scan stands for dual energy X-ray absorptiometry, and it's a non-invasive body scan that's the gold standard for diagnosis. It measures our bone mineral content at 3 different sites and then compares that to the bone mineral density of a reference matched population. And when you're interpreting it, we interpret the T-score, which is representing the number of standard deviations that a particular patient's bone mineral density differs from the reference. And it's validated in peri and postmenopausal women and men over 50. And then alternatively, a Z-score can be used in patients that fall outside of that population and in combination with fracture history in pediatrics. Each standard deviation decrease in bone mineral density is associated with a 2-fold increase in fracture risk. So prior to transplant, DEXA scans can be helpful in pre-liver, lung, and heart transplant patients to identify pre-existing bone disease and start preventative treatment early. It can also provide baseline risk and help us guide immunosuppressive regimens after transplant, such as avoiding steroids. But it's just important to note that if they have a normal T-score before, it doesn't mean they're not at risk for fractures after transplant. In comparison, interpretation of DEXA scans in renal failure patients is a little bit more controversial. And this is because DEXA scans are just identifying low bone mineral density, but not differentiating between the different forms of renal osteodystrophy that are common in this population. So it's not discerning between osteoporosis and adynamic bone disease, which is a low bone turnover state. And this is important because bisphosphonate therapy can be harmful in adynamic bone disease. So really the most accurate method is through a bone biopsy. but we don't see this used that much in clinical practice. After transplant, Dexa scans can be used to assess the risk and need for treatment. Medicare covers Dexa scans every 2 years, so it's important to check when patients last had one done before ordering one after transplant. Guidelines haven't been updated too recently, but they have some recommendations for within the first 5 years after transplant. In heart transplant patients, ISHLT recommends a Dexa scan at 1 year for all recipients, followed by every 1 to 3 years, depending on risk factors. For liver transplant patients, it's recommended annually if they have osteopenia, or every 2 years if normal bone mineral density. And then lastly, the KDIGO guidelines were recently updated in 2017. Prior to that, they had specific recommendations for testing within 3 months if risk factors or steroid therapy, but they're now reworded and a little bit more vague, suggesting bone mineral density testing if the results will alter therapy. And then lastly, just to mention FRAX tool or fracture risk assessment tool. It's another diagnostic tool often used in primary care practice. Since the Dexa scan only looks at one factor, the bone mineral density, this tool was developed to incorporate other clinical factors that increase fracture risk. So it's kind of like the ASCVD risk calculator. You input your patient information, and then it calculates a 10-year probability of a fracture in untreated patients. It hasn't been studied that much in the transplant population, so I caution use just due to reports of it underestimating risk in patients on higher doses of steroids. And it also only incorporates bone mineral density at one site, the femoral neck, and doesn't include lumbar spine or hip, which are common sites of fractures in our patients. So I'll turn it over to Mary Grace now.
So next, we will discuss a little bit about the pre and post-transplant risk factors for osteoporosis. And next slide. The post-transplant osteoporosis can really potentially affect morbidity and mortality. The consequential reduction in bone density is substantial, especially in the first year post-transplant, and contributes to an increased risk of fractures. For example, significant reductions in bone mineral density have been reported after kidney transplantation, particularly at the lumbar spine. About 23% of kidney transplant recipients experience a fracture in the first 5 years after transplant. With reduced use of steroids post-transplant, the risk of fracture has decreased tremendously compared to the past. However, what's really important to note is that fracture risk post-transplant is still higher than it is in the general population. There are several general risk factors for osteoporosis. The pre-transplant risk factors for osteoporosis include female sex, especially if they're postmenopausal, BMI less than 23, diabetes, malnutrition, a sedentary lifestyle, excessive alcohol, both of which can be pre or post-transplant, vitamin D deficiency, lack of sun exposure, hypogonadism, patients who have several falls, or potentially end organ failure or pre-existing bone mineral abnormalities. Next slide. There are several risk factors for osteoporosis that patients in need of a kidney transplant face, such as time on dialysis and the presence of underlying secondary hyperparathyroidism, which generates continued alterations in bone morphology post-transplant, which leads to persistent high turnover bone disease. Approximately 30 to 50% of patients continue to have hyperparathyroidism post-kidney transplant as well. Additionally, these patients can have hyperphosphatemia or low vitamin D levels. Then, once transplanted, patients with suboptimal renal graft function continue to suffer from renal osteodystrophy, hypomagnesemia, and low calcitriol levels from delayed graft function can also increase risk for osteoporosis. And like all patients post-transplant, immobilization and medications, which will be discussed in more depth shortly, contribute to the significantly increased risk of osteoporosis. Next slide. Compared to pre and post kidney transplant patients, there's less data in end-stage liver disease. Chronic liver disease patients typically manifest as low turnover bone disease secondary to osteoblast dysfunction. Decreased IGF-1 or insulin-like growth factor 1 levels leads to decline in bone mass and bone density. Hyperbilirubinemia can cause inhibitory effects on osteoblast proliferation and differentiation. End-stage liver disease patients often have vitamin D deficiency due to fat malabsorption from cholestasis, thereby increasing osteoclast activity. Patients with primary biliary cirrhosis are often at higher risk due to chronic glucocorticoid use. And then, as previously mentioned, alcohol intake is also a risk factor for bone disease as well. The post-liver transplant risk factors are similar to other organ groups. Next slide. Among all cardiac patients, congestive heart failure patients experience more significant bone loss compared to others. Along with general risk factors contributing to low bone mass, such as vitamin D deficiency, cardiac-specific risk factors prior to transplant include patients with renal failure associated with heart failure, which leads to secondary hyperparathyroidism, and therapy with loop diuretics, which can lead to increased calcium excretion from the body. Post-transplant are also similar to other organ groups. Next slide. And finally, for lung transplant, in a longitudinal study by Wang and colleagues involving lung transplant patients, pre-transplant osteopenia and osteoporosis were prevalent in 36% and 31% of patients respectively. Reduced bone mass is seen in end-stage lung disease patients, particularly in patients with COPD and cystic fibrosis. Abnormalities in osteoblasts are predominantly seen in patients with COPD. However, in patients with CF, increased bone resorption is seen due to hypogonadism, malnutrition, inflammatory cytokines, and impaired calcium and vitamin D absorption from pancreatic insufficiency. There is some evidence to suggest that hypoxia potentially can promote osteoclast activity, although the literature is somewhat limited and also conflicting. And then finally, tobacco smoking causes an imbalance in bone turnover, leading to lower bone mass and making bone more vulnerable to osteoporosis and fractions. One thing specific to the post-lung transplant population is the often prolonged use of glucocorticoids compared to other organ groups. These patients may also not be able to withstand steroid avoidance given their increased risk for rejection. Next slide. Next, one of the most important and sometimes non-modifiable risk factors for development of osteoporosis post-transplant is the medications used to prevent rejection. Next slide. Glucocorticoid therapy has been a mainstay of immunosuppression regimens for many years in most organ groups, at least early on post-transplant. However, glucocorticoid therapy is associated with an appreciable risk of bone loss. Steroid use is the most common cause of secondary osteoporosis in patients prior to age 50. Bone loss and increased rate of fractures occur early after initiation of steroids and can be seen as early as the first 3 months of therapy. Then they are related to dosage and treatment duration. Steroid-induced osteoporosis is characterized by increased apoptosis of osteoblasts and osteocytes, decreased osteoblastogenesis, resulting in decreased bone formation, and disruption of bone modeling regulation. Additionally, after initiation of glucocorticoid therapy, there is an early and transient increase in bone resorption through enhanced osteoclast survival and osteoclastogenesis, which later then changes to decreased osteoclastogenesis. Ultimately, this combination of increased bone resorption, decreased bone formation, and interruption of regulatory pathways explains the observations of an early and rapid loss of bone mineral density. And Julie, if you can click the slide. As well as bone strength and quality in patients with steroids-induced osteoporosis. Steroids also increase the expression of the rank ligand, which we will address later on. Even prednisone 5 milligrams daily is enough to rapidly and significantly decrease the markers of bone formation, and the changes can be reversed after discontinuation of prednisone. In addition to the direct effects of steroids, as previously mentioned on the slide, there are also some indirect effects of steroids. These include myopathy, which then causes muscle weakness, increases risk for falls, and reduces physical activity. There's also reduced production of sex steroid hormones and hypogonadism, increased renal and intestinal losses of calcium, and reduced production of IGF-1. IGF-1 is an important anabolic hormone and has ability to regulate bone homeostasis and maintain skeletal architecture. Decreased levels of this have been shown to strongly contribute to the occurrence of osteoporosis fractures, as levels are correlated with bone mineral density. Next slide. Calcineurin inhibitors, both tacrolimus and cyclosporin, are the immediate post-transplant backbone of immunosuppressive regimens across all organ groups. However, CNIs cause hypomagnesemia, which can lead to elevated levels of parathyroid hormone. Secondary hyperparathyroidism, as mentioned previously, post-transplant, will accelerate high turnover bone disease, potentiating increased osteoporotic fracture risk. The ways in which tacro and cyclosporin have been observed to impact bone is slightly different. Cyclosporin stimulates osteoclast activity more so than osteoblast activity, which results in net bone loss. Tacrolimus, however, induces severe trabecular bone loss, but interestingly is thought to be less severe than cyclosporin. The trabecular bone is porous bone composed of trabeculated bone tissue, which is often found at the end of long bones like the femur or in vertebrae. Next slide. I just wanted to briefly touch on other immunosuppressive medications used post-transplant, including the mTOR inhibitors, azathioprine, and mycophenolic acid. Limited data is available regarding the effects of these meds on bone mineral metabolism. However, previous rodent experiments did not show any effect of the above-mentioned immunosuppressive meds on bone volume. And I'll pass it back to Julie to talk about prevention of osteoporosis.
So like I mentioned before, prevention is essential in preventing osteoporosis progression in transplant, specifically in patients with osteopenia, but also patients with normal bone mineral density at time of transplant. So prevention considerations that can be implemented in all organ types include early mobilization after transplant, fall prevention measures, and alcohol and smoking cessation. Additionally, weight-bearing exercise as tolerated. Medication-related considerations include continuing treating for underlying causes such as secondary hyperparathyroidism, and then calcium and vitamin D supplementation plus or minus anti-resorptive therapy, and then adjusting immunosuppressive regimens for steroid minimization or withdrawal. Calcium is necessary to maintain bone strength at the time of transplant. Like we mentioned, many patients have vitamin D deficiencies or secondary hyperparathyroidism, and this will reduce calcium absorption. This should correct after transplant, but not immediately. Recommended daily calcium intake is 1,000 to 1,200 milligrams per day, combined from diet and supplementation. And it's recommended to avoid doses greater than 2,500 milligrams per day due to the risk of constipation, kidney stones, and inhibition of other minerals. So the two most common formulations, as I'm sure you're familiar with, are calcium carbonate and calcium citrate. Carbonate is the least expensive formulation. It has to be taken with food because of acid-dependent absorption, so shouldn't be co-administered with acid suppressants, and has GI-related side effects. Calcium citrate, therefore, tends to be more preferable in transplant patients. It can be taken with or without food and in patients on acid suppressive therapy. And it's important to keep in mind this recommended intake is from diet and supplementation. So it's always a good idea to consult our dietitian colleagues after transplant to make sure patients are educated on how to maximize their nutrients from their diet, especially if they were limited in certain food groups before transplant. And this could help reduce the pill burden from decrease the amount of supplementation they need in the form of pills. So just to put it in perspective, an 8-ounce glass of milk or an 8-ounce glass of orange juice has 300 milligrams of calcium, and a 6-ounce cup of yogurt has 250 milligrams of calcium. And vitamin D is important for calcium absorption and bone mineralization. A lot of patients are coming into transplant with vitamin D deficiencies, and this is defined as a serum 25-hydroxy D level less than 12, or with an insufficiency, which is a level of 12 to 20. Normal vitamin D levels are considered greater than 30, so there's kind of a little gray area between 20 to 30. But nonetheless, all patients with vitamin D levels less than 20 should be started on supplementation to make sure that we boost their vitamin D levels up to normal and then should be considered for secondary prevention to maintain normal vitamin D levels. So the recommended vitamin D intake is 600 to 800 international units per day. And this is specifically for prevention. So those that are insufficient or deficient will require higher amounts for repletion. And this is again through diet and supplementation, as well as contributing from sunlight exposure. So an 8-ounce glass of regular milk has 100 international units per vitamin D. It could contain more if it's fortified. And then a lot of our vitamin D from food comes from fish products like salmon and tuna. For vitamin D formulations, we have ergocalciferol or vitamin D2, which is derived from plant-based sources, and then vitamin D3 or cholecalciferol from animal-based sources. And these precursors undergo hydroxylation in the liver to become calcidiol or 25-hydroxy vitamin D. And this is what we're measuring in the serum when we measure vitamin D levels. And that undergoes hydroxylation again in the kidneys to the most active form, calcitriol. For prevention, doses typically range between 400 to 2,000 international units per day, and most commonly see that in the D3 formulation. And then for treatment of insufficiency or deficiency, typically see 50,000 units weekly of the D2 formulation for a couple of months and then reassess. Calcitriol can be helpful in patients with renal impairment, as this population often has loss of 1-alpha hydroxylase enzyme in the kidneys that's needed to convert these precursors to calcitriol. And then since vitamin D levels increase calcium and phosphorus absorption, it's important to monitor levels routinely while on supplementation. And then again, vitamin D levels should be monitored approximately 3 months after initiating therapy. Bisphosphonates are the most common class of medications used to treat osteoporosis, but they're also used in prevention in certain patients with risk factors. They work to inhibit bone resorption through interference with osteoclasts, leading to an indirect increase in bone mineral density. So for prevention, there's 3 agents most commonly used. Orally, we have alendronate and risendronate, and then IV, we have zoledronic acid. The dosing on this slide is representative of glucocorticoid-induced prevention. So the dosing may be different for treatment or also prevention in other populations such as menopause. The oral agent should be given on an empty stomach in the morning prior to food and all other medications, followed by sitting upright for 30 to 60 minutes. So this can be challenging in some of our transplant patients that already have an extensive medication regimen and often come to the transplant clinic on weekdays, mornings. So from a practicality perspective, the weekly alendronate is a good option to decrease the pill burden, or the zoledronic acid, since it's only given once a year, but it is an IV infusion. Limitations of these agents are that they're not recommended to be used in renal impairment. So this is why we see a lot of kidney transplant patients coming in at time of transplant with osteoporosis, not on bisphosphonate therapy. There's limited literature on the use of these agents in the transplant population specifically for prevention, but I've selected a couple of studies to go through. The first one comes out of Australia by Crawford and colleagues. This was a randomized trial of 62 liver transplant patients that received zoledronic acid for prevention of osteoporosis. Most patients had osteopenia at time of transplant, and they were on immunosuppression with a calcineurin inhibitor, antimetabolite, and prednisone. And just to put the steroid dose in perspective, the mean daily prednisone dose at month 3 was about 9 to 10 milligrams, and at month 6 was about 6 milligrams. So they compared patients that got zoledronic acid 4 milligrams IV within a week of transplant, and then again at months 1, 3, 6, and 9, plus calcium and vitamin D, compared to a control group of calcium and vitamin D. So immediately when I look at this, you see the zoledronic acid dose is a lot higher than what we use in practice. in terms of the frequency that they were giving this medication. What they found was there is a reduction in bone loss with the zoledrinic acid group. So these graphs are looking at the percent change in bone mineral density at lumbar spine, femoral neck, and total hip. And that percent change was greatest earlier post-transplant, so at 3 months in comparison to 12 months. But this study did not look at fracture. The second study was also in liver transplant patients, now looking at oral alendronate in 98 patients for up to 24 months after transplant. So they gave the weekly alendronate plus calcium and calcitriol compared to just calcium and calcitriol. These patients were on a CNI plus prednisone that was tapered around 6 months post-transplant. They saw rapid improvements in bone mineral density in the patients that got alendronate, but they did also see a small increase in bone mineral density in just the control group. So they were concluding that just calcium and calcitriol also has a positive effect on the bone mineral density, but it was higher in the alendronate group. And this study also reported fracture outcomes. So although not statistically significant, numerically, there were less fractures in the alendronate group compared to the control group. And similarly to the other study, a lot of patients had osteopenia at baseline. Another study then that came out of Columbia in 2012 was looking at zoledrinic acid versus alendronate, specifically for prevention in both heart and liver transplant patients. The dosing is similar to what we use in practice today, either zoledrinic acid once or alendronate 70 milligrams weekly or placebo started within the first month of transplant. These patients had slightly different immunosuppressive regimens based on which organ, but they were mostly all on a calcineurin inhibitor with a prednisone taper. They saw that bone mineral density declined at all 3 sites in the placebo group. It remained stable in the total hip and femoral neck in both treatment groups. And then at the lumbar spine, they saw a significant increase in bone mineral density in the zoledrinic acid group and a slightly small change in the alendronate group. When this was further broken down by organ type, they specifically saw that the results were of zoledrinic acid were superior in the heart transplant group. And something unique that this study looked at was serum C-telopeptide, and this is a bone resorption marker. When they looked at this and broke it down by all patients, heart patients, and liver patients, they found that the percent change in the CTX marker was more significant with the zoledrinic acid group, specifically in the heart transplant population, and they didn't see any changes in the bone resorption marker changes in the liver transplant group or with alendronate. And then one more study looking at prevention. This was a meta-analysis from the same author group as the previous study, and it looked at bisphosphonates and calcitriol on fracture risk. So they looked at 11 studies, 9 of which had bisphosphonate therapy and 2 had calcitriol. There was a mix of all organs represented, and most patients were on immunosuppressive prednisone, cyclosporin, plus mycophenolate or azathioprine, and then all patients had calcium and vitamin D. They were mainly looking at fracture risk, and this had about 780 patients total, and they saw that use of bisphosphonates or calcitriol significantly reduced the amount of fractures, and specifically the amount of vertebral fractures, and had a positive impact on increasing bone mineral density. So what did the transplant guidelines recommend specifically for prevention? So again, these aren't updated too recently, but for heart transplant patients, it's recommended to use calcium and vitamin D supplementation, as well as anti-resorptive therapy for the first year, and then reassess at 1 year and consider stopping if either steroids are discontinued or they have a T-score greater than 1.5. For liver transplant patients, again, calcium and vitamin D supplementation, and then considering the anti-resorptive therapy for treatment if they have osteoporosis, or for prevention if they have osteopenia with other risk factors. And they do comment that the preferred agent is weekly alendronate. And then for kidney transplant patients, vitamin D supplementation is recommended. And then considering anti-resorptive therapy if they have, if they don't have impaired renal function and have low bone mineral density. But again, there's the risk of potential harm in using bisphosphonates with adynamic bone disease. So it's recommended to consider bone marrow biopsies. There is the 2017 American College of Rheumatology guideline for preventing glucocorticoid-induced osteoporosis. They do have a section on transplant patients and recommend they be treated like any other population in accordance with how much steroids they're receiving. So with that being said, it's recommended per this guideline that all patients taking prednisone doses of at least 2.5 milligrams per day for 3 days have optimal calcium and vitamin D supplementation, specifically for prevention. And then just 2 studies that show, so we went over what medications we can use for prevention, but also adjusting immunosuppressive regimens because of the effects of steroids on osteoporosis. I think this is important too, as our transplant patients are living a lot longer. They are more prone to developing osteoporosis from steroids long term. So this was a retrospective study of 57 kidney pancreas transplant patients. It wasn't specifically an intervention, but it was looking at the effect of reducing steroid doses over time and how that affected bone mineral density up to 4 years post-transplant. So the table on the top, I highlighted the steroid dose, prednisone, about 20 milligrams in the first year. And by year 4, these patients were on about 1.3 milligrams of prednisone per day. About a third of them had osteoporosis at baseline. And what they saw over time, there was a significant improvement in their T-scores at 1 year. And then this continued over time as the steroid doses were reduced. So showing that we're reducing the steroid dose, improvement in bone mineral density and T-score. And then one last study in transplant patients. This was a retrospective review of kidney transplant recipients between 2000 and 2006, comparing early steroid withdrawal, which meant no steroids upon hospital discharge, with standard corticosteroid-based immunosuppression. And they found that steroid withdrawal was associated with a 31% fracture risk reduction with similar graft survival. And this was at 1 year post-transplant and then up to 5 years post-transplant. So just some steroid minimization techniques in preventing osteoporosis include using the lowest doses possible for the shortest duration possible per your organ-specific and center-specific protocols, and then considering using induction methods like lymphocyte depleting agents that reduce the need for steroids, and then also using combinations of other immunosuppressive agents to reduce the dose requirement of steroids. So I'll turn it back over to Mary Grace now for treatment.
I'll go ahead and go to the next slide. So I just wanted to briefly include this picture here that talks a little bit about mechanism of action of available osteoporosis therapies. I will primarily focus on bisphosphonates and denosumab, but we'll briefly touch on PTH analogs and estrogen therapy at the end of the presentation. Next slide. As Julie previously mentioned with the 2017 ACR guidelines, there is a section specifically, and Julie, if you can click through 3 times here, there are several recommendations with regards to adults with an organ transplant, GFR greater than 30, and no evidence of metabolic bone disease who continue treatment with steroids. The first recommendation is to treat according to the age-related guidelines for patients without transplants. These recommendations include treating with calcium and vitamin D in patients with low fracture risk, treating with calcium and vitamin D plus an additional osteoporosis medication if they're moderate to high, and then other recommendations if they are at serious risk of fractures. The guidelines, however, recommend against treatment with denosumab due to lack of adequate safety data on infections in adults treated with multiple immunosuppressive agents. I would like to talk about this a little bit further in the presentation to kind of address this recommendation. These are ultimately conditional recommendations due to low quality evidence with solid organ transplant patients. Next slide. First, I'd like to review the guideline recommended agents within the bisphosphonate class. Julie previously reviewed this class, but I just wanted to highlight the medications and dosages specifically approved for treatment of osteoporosis as listed here. In almost all studies of bisphosphonates, the patients were concurrently obtaining adequate calcium through supplementation or diet. Next slide. A very important part of utilizing these medications in transplant recipients, as Julie had on her previous slide as well, is understanding the strict administration recommendations. This is particularly important to transplant patients as they already often have complex medication regimens with administration times all throughout the day. Adding to these regimens should not be taken lightly, and significant medication counseling is required. Bisphosphonates should be taken first thing in the morning, 30 minutes prior to food, drinks, or any other meds. Patients should not lie down flat for at least 30 minutes after the dose and after first food of the day. So for example, a bisphosphonate may best be taken around 7 or 7:30 in the morning with at least 30 minutes prior to the next medication. For example, maybe a proton pump inhibitor that needs to be given before meals to prevent GI ulcers in patients on steroids, and while the patient's sitting up, and then followed by the patient's breakfast and their 9 o'clock transplant medications. The patient could also consider taking their calcium and vitamin D supplements around lunchtime to avoid interfering with absorption with bisphosphonates or other meds they may be taking at 9 o'clock. So as you can see, this medication regimen can become even more complicated quickly, especially with a patient who may have lower health literacy or require caregiver support for medication administration. So because of these strict requirements, these agents should be avoided in populations with delayed esophageal emptying or dysmotility. Importantly, this may limit use in, for example, some lung transplant recipients who may already have this esophageal complications or develop it post-transplant. They are also not benign therapy with adverse effects listed on the slide here. And finally, a really important limitation of bisphosphonate therapy to note is the creatinine clearance cutoff, as they are not recommended for patients with a creatinine clearance less than 35 due to lack of data in this population. Next slide. The bisphosphonate trials have excluded patients based on pre-specified renal measurement cutoffs as they are cleared via glomerular filtration. The reduced renal function post-transplant, or for example, renal transplant patients with delayed graft function, may result in excessive bisphosphonate retention. So denosumab may be an attractive option for increasing bone mineral density in patients with renal dysfunction, as it is not cleared renally. By binding with high affinity and specificity to the RANK or RANK ligand, denosumab prevents the RANK ligand from activating its receptor on the surface of osteoclasts and their precursors. Inhibition of the RANK and RANK ligand interaction decreases bone resorption and increases bone strength. Next slide. Denosumab, I have the dosing specifically listed for the brand Prolia listed here, as that's indicated for osteoporosis treatment from steroids. Xgeva is often utilized in patients with cancer or on chemotherapy, which I won't talk about in this presentation. The adverse effects most commonly include things listed on the slide. However, the vast majority of osteonecrosis of the jaw cases have occurred in the oncology patients receiving higher doses, or patients without good dental hygiene, or patients who are smokers. Importantly about this medication is it requires no renal dose adjustments. So it may be a new attractive option for those patients with delayed graft function or renal dysfunction. However, the package insert does note that patients on concomitant immunosuppressive agents or with impaired immune systems may be at increased risk for serious infections. Next slide. I'd first like to review the study produced by Bernuba and colleagues. It was published in 2018, which is a retrospective cohort of 63 patients after solid organ transplant, including patients who underwent a simultaneous pancreas kidney transplant alone, or liver transplant alone. They received denosumab every 6 months from 2012 to 2017. And they did have to have presence of low bone mineral density values and a T-score less than or equal to -2.5 at the L-spine or the femur. The period of time since transplant ranged from between 0 and 24 years upon beginning denosumab therapy. Patients were either on this calcineurin inhibitor, mycophenolate, sirolimus, and steroids in various doses. The average prednisone dose was 5 milligrams per day. Calcium and vitamin D supplementation before and during therapy was also administered, and the minimum treatment duration was at least a year. Of note, the median GFR was 33 at the beginning of therapy. Next slide. After therapy, the L-spine T-score improved in all organ groups, reaching -1.8 with a statistically significant difference. Hip T-scores values also increased after therapy and with a statistically significant difference. There was only a mild statistically insignificant improvement in the distal radius T-score, which I did not show on this slide. Next slide. The lumbar spine bone mineral density improved in all treated patients. The bone mineral density of the proximal femur improved in 94% of patients, and bone mineral density of distal radius increased in 52% of patients. And if you could advance the slide. The authors conclude that denosumab therapy markedly improved bone mineral density in solid organ recipients. A significant increase in T-scores was observed at the L-spine and hips, and the prevalence of osteoporosis in the L-spine decreased by 48% and in the hips by 18%, even following only potentially a minimum duration of only 1 year. A significant advantage of denosumab therapy is that it can be used in patients with impaired renal function, and it's not known to exhibit any adverse interaction with other medications currently in use. Subcutaneous administration every 6 months is also much less burdensome for our post-transplant patients who are administered large daily doses of other meds. It may also have a favorable effect on post-transplant bone loss due to the effect of calcineurin inhibitors on osteoclast activity and steroid activation of the rank ligand system. Denosumab therapy in this trial was well tolerated, and the authors did not observe any serious complications. However, there did not observe any particularly increased in risk of infectious complications, but I'll review the safety profile in more depth in just a few minutes. Next slide. Denosumab therapy, based on that trial, is looking pretty attractive to our post-transplant patients. So I wanted to look at a study that compared the effectiveness between denosumab and our otherwise first-line standard of care with bisphosphonates. This trial was a retrospective trial of 85 renal transplant patients with a minimum of 2 bone mineral density measures. They received denosumab or bisphosphonate therapy for at least a year. Next slide. I have the baseline characteristics listed here. Of note, the significance was set with a p-value less than 0.05, and there was no significant differences between groups, including the baseline T-scores at both the neck and spine, as well as the baseline prednisone dose per day. Next slide. The comparison of absolute changes in bone mineral density at the final follow-up between the treatment groups is listed here. The absolute change in bone mineral density from baseline at the femoral neck and lumbar spine in the denosumab and bisphosphonate treatment groups are shown in the blue and gold bar chart there. At final follow-up, denosumab resulted in significantly greater increases in lumbar spine bone mineral density and increased femoral neck bone mineral density as well. And then advance the slide. And even further, at year 1, 2, and 3, the denosumab group recorded higher absolute lumbar spine and femoral neck bone mineral density. There was no significant changes in either of these parameters at final follow-up in the bisphosphonate treated patients. Next slide. The denosumab group, I have listed some reports of side effects listed here. One serious event of hospitalized hypocalcemia. The bisphosphonate group did have 5 patients that reported GI effects, and 2 patients discontinued and switched to denosumab. Importantly, there were no reports of osteonecrosis of the jaw or avascular necrosis in either group. And next slide, or advance the slide. The present study provides evidence for the greater effects of denosumab treatment in increasing lumbar spine bone mineral density compared with bisphosphonate treatment at final follow-up. This really has great implications for current treatment decisions on increasing bone mineral density, where decreased GFR in renal and CKD patients is an area of concern. The impact of denosumab is also more pronounced on cortical bone, which affects microarchitectural outcomes beyond just increasing bone mineral density. Next slide. So as I alluded to a little bit before, the guidelines warn against the use of infection risk with denosumab, as well as some reports for previous trials. So with the introduction of these novel agents, particularly drugs that affect the immune system, we are concerned about these unexpected infectious complications. And we know that osteoporosis is seen as early as 6 months post-transplant, when infection risk may be higher and immunosuppression levels are higher. Therefore, I pulled this trial from Banani and colleagues in 2017, which was a prospective single-center randomized trial that looked at 90 renal transplant recipients who received denosumab or no treatment and were followed for 1 year. Their immunosuppression therapy is listed there. All patients also received prophylaxis with Bactrim for pneumocystis jirovecii prophylaxis and UTI infections in the first 6 months post-transplant. CMV was also approached with a preemptive strategy. So for patients with CMV, prophylaxis with daily Valsite for the first 3 months was only prescribed to high risk and intermediate risk if they received thymo induction. Next slide. There were 99 events total in the control group compared to 146 infectious events in the denosumab group. I did just include the most relevant ones here on the slide. The number of infections per patient tended to be higher in the denosumab group than control, with a median of 3 versus 2, but was not statistically significant. The number of patients with any infection was not different between the 2 treatment groups. The most common infections were urinary tract infections, CMV viremia, flu-like syndrome, BK viremia, and herpes simplex infections. What I think is important to note is that the episodes of UTIs occurred in more patients in the denosumab than in the control group, but the number of episodes with CMV viremia, flu, BK viremia, and herpes simplex did not differ between groups. Next slide. So I'd like to highlight a little bit about the cumulative incidence of urinary tract infections in both of these groups. The episodes of UTI occurred in more patients in the denosumab than in control, whereas transplant pyelonephritis and urosepsis showed no difference in the 2 groups. Clinically, the 51 episodes of UTIs in the denosumab group were of mild, which was 4%, moderate, 76%, or severe, 19% degree. Therefore, most of the UTIs were determined to be moderate. The 25 episodes of UTIs in the control group, however, were 56% determined to be moderate and 44% determined to be severe. So the fraction of severe episodes was actually higher in the control group than in the denosumab group. Next slide. The post hoc analysis of this study did reveal a higher number of infections in the denosumab group. And in particular, it did lead to a doubling of the number of UTIs, whereas other type of infections were not more common with either group. The mechanisms which lead to such a high number of UTIs are probably multifactorial. It has been suggested that the inhibition of the rank ligand pathway with denosumab could decrease the resistance to microbial organisms. However, this is by unknown mechanisms. Fortunately, the UTIs in both groups represented mostly benign episodes of cystitis, which could easily be managed with antibiotics, and transplant pyelonephritis or urosepsis were not more common in the denosumab group. I then would just like to briefly go back and review the previous trial that I discussed with Brunova, which was published after this study. So the Brunova trial actually did not observe any increased incidence of infections in denosumab treated patients in comparison with other graft recipients at their institution. So in most of their patients, they did not experience any significant increase in UTIs. However, the significant period of time had elapsed since their transplant as compared to this study. If you could click, please, Julie. In conclusion, there should be caution regarded to UTIs and possibly wound, skin, or herpes zoster or simplex infections. And caution should be advised when using denosumab early after renal transplant when immunosuppression is at the highest level. And thus, very briefly, I'd just like to review additional therapies that exist for treatment of osteoporosis. Teriparatide is a synthetic recombinant human parathyroid hormone that binds with high affinity to cell surface receptors, similarly to endogenous PTH. With once daily use, it does stimulate osteoblast activity over osteoclast activity, which results in new bone formation on the trabecular and cortical bone surfaces. Next slide. I did just want to present this trial for your information. There is not a lot of data with the effect of teriparatide on early bone loss in transplant in general. This was a very small study looking at 24 patients that were recruited for a prospective double-blind placebo-controlled study. So this was more for prevention than for treatment. And patients with delayed graft function were excluded. Patients either received the teriparatide or placebo. All subjects were also given calcium and vitamin D as well. And if you could click just to show some of the differences in bone mineral density. The femoral neck bone mineral density was stable in the teriparatide group, but however decreased significantly in the placebo group. The lumbar spine and radial BMD status remained unchanged in both groups, and the serologic bone markers were similarly reduced in both groups. And if you could just advance the slide. In conclusion, really, teriparatide did not have much change on bone mineral density compared to placebo. And here I have listed other therapies that potentially are sometimes used, such as hormone replacement therapy or calcitonin. I've just listed this for reference if anyone would be interested in reading it further, but this really, there's not a lot of data that exists, especially not in treatment. It's really only in prevention for both hormone replacement therapy and calcitonin. There's some preliminary data that suggests that calcitonin may help restore bone mass in kidney transplant patients, but it really was just a very small, limited study. And next slide. So in conclusion, osteoporosis-related fractures in transplant patients result in consequences such as decreased quality of life, limited mobility, and increased healthcare costs. Many pre- and post-transplant risk factors contribute to osteoporosis development, and the most prominent is glucocorticoid use. Early prevention post-transplant with calcium, vitamin D, and with or without bisphosphonates is essential to avoid progression to osteoporosis. Bisphosphonates are first line in the 2017 guidelines. However, denosumab has begun to demonstrate superior efficacy. Recommend denosumab for patients with delayed graft function, but caution should be utilized with increased infection risk early on post-transplant with denosumab use. And with that, we were happy to take any questions.
Thank you so much, Julie and Mary Grace. If anyone has any questions, you can feel free to put those in the chat. You can direct them to me, or you could direct them to the whole group at this point, or I think you should be able to turn your microphones on as well. And I'll kind of get us started. I'm just curious from both of you, in your practice from kind of a practical perspective and what you see on a day-to-day basis, what do you feel like we're kind of doing, exceptionally well when it comes to caring for our patients, and where could we potentially, improve, or what kind of, holes in research and data do you see that you'd like to see filled?
I can go ahead and answer that first. So I think to answer the first question, something that at least I've only been at one center after residency, so I can speak at least from my own center that I'm at now. One thing that we've started to do is collecting vitamin D levels when the patient gets called in for transplant. So we have a baseline that we can trend thereafter, and it starts prompting us to think about giving those supplements early on, even within their index hospital admission, which was something I think that was a pretty easy and not super costly fix that has seemed to help our patients. And it also helps them getting used to using those medications early on after transplant, especially when they're taught about how to take all their medications. One thing just of my personal opinion, I think that would be helpful, as Julie probably noticed too, of course, a lot of data is in renal transplant patients. And if we were to review all the data, we would have to do a separate presentation. But I know our lung transplant patients, at least the ones I see, suffer a lot with these issues, but I feel like the data is somewhat lacking. So it would be helpful to have more broad data with other organs outside of our renal transplant patients. I think of the lungs first because, at least in our population, we typically don't wean them off steroids, at least for a very long time.
Yeah, I agree with what Mary Grace said about at my institution too, we obtain vitamin D levels at the transplant index admission and make sure we are coming up with a plan if they need repletion or if they just need prevention, and making sure those medications are ordered. I think in another area that we kind of have a gap in is maintaining the follow-up on this. So I know I've been at different transplant centers. Where I am now, we follow our transplant patients long-term. I know other centers, they kind of turn them over to general nephrology, but making sure that someone's following up with these therapies that we're starting at the time of transplant to assess their risks and follow up on care, I think is a gap that we can continue to work on.
Absolutely. And kind of just in follow-up to that, I was personally curious in your experience and kind of your practices when it comes to actual treatment. So if you were to have a Dexa and the patient did actually warrant treatment, is there kind of a decision point as to when the transplant team is addressing that themselves versus potentially referring the patient to a specialist to address?
I think when patients are actually diagnosed with osteoporosis, it would be helpful to refer them to endocrinology, especially a lot of patients are already in contact with endocrinology for diabetes management or other things like that. But I think when it's just primary prevention from the steroids, it's a good opportunity for or at least at my center, the transplant team kind of taking the reins on that.
I agree for the most part with what Julie said too. The only difference I'll add from my center is we're in Detroit, so the patient population we see is often very underserved, or they live very far away from Henry Ford and more remote areas. So I have noticed that our transplant nephrologists are often managing a lot of chronic comorbidities because they don't have access to a PCP or endo. So I think our providers are managing a lot, and that can sometimes hinder their ability to keep up with all of the things that they have to kind of think about outside of transplant. So I think in an ideal world, I totally agree getting them into endo, but I think sometimes our providers are kind of left with initiating that therapy and dealing with potentially insurance coverages of the injections or infusions, which can be challenging.
Absolutely. And then we did have a question in the chat. I'm not sure if you guys are able to see that from Amanda, but given that a lot of our solid organ transplant patients have some degree of CKD, when are we missing this? When are we missing the CKD, MVD? And are your centers rescreening any of your non-kidney transplant patients for any of those derangements?
I only work at a kidney transplant center, so I can't really comment on the other organs, but I think it's important as a center defining some threshold after transplant, whether it be 2 or 3 months to rescreen.
Yes, at my center, at least one organ group that does it really well outside of kidneys are the lung transplant group, especially because they often also have CKD as well. They include in part of our notes when they see the patient in clinic, if they need a Dexa scan or if they need a referral to endocrinology or their last vitamin D levels. So it's something that we're constantly thinking about for those patients, but I would still say regardless, we're probably missing it a lot in potentially the hearts and livers where maybe we're not thinking about it as much, although we do taper them off steroids at some level. If patients are treated for rejection, they're right back on them. So I think there's always more screening that can be done, even if it just starts with checking vitamin D levels or screening them based on their age or other kind of non-modifiable factors as well outside of transplant.
Did we have any other questions from the group? If not, I know that everyone here appreciates all of your time, from both our speakers and our participants, for joining. And I know that the committee would welcome any feedback regarding future webinars as well. So thank you all so much for joining.